Welcome to the deep dive. Our mission here is pretty simple. We take the most complex clinical guidelines, the freshest scientific data, and these massive shifts in medical strategy, and we try to synthesize them into knowledge you can actually use.
And today we are wrestling with what is, a genuine healthcare revolution.
Mhm.
We're talking about the impact of GLP-1 and GIP-GLP-1 receptor agonist medications.
Mhm.
These drugs aren't just a new tool in the toolbox. They are completely resetting how we define and treat two of the most prevalent chronic conditions in the United States.
Type 2 diabetes and obesity.
Exactly.
And the scale of this is it's immense. You mentioned obesity, and our sources confirm the staggering fact that approximately 42% of adults in the U.S. alone suffer from it.
42%.
That number means we're talking about a treatment with a potential user base in the, tens of millions?
Yeah.
The impact on public health, cardiovascular risk, quality of life,
Mhm.
it's hard to overstate.
It is a massive clinical opportunity. The efficacy of these agents for both significant weight loss and enhanced glycemic control is why they're so transformative.
Right.
But, as with any widely adopted, powerful pharmaceutical agent, a core challenge emerges.
Managing the side effects.
That's it, managing the side effects.
Yeah, everybody hears the headline, right? Significant weight loss drug. But they often miss the fine print. The undercurrent of this entire drug class is gastrointestinal distress.
Precisely. We are talking about mild to moderate GI disturbances, nausea, vomiting, diarrhea, constipation. They are very commonly reported. And while, on the surface, these might sound like just manageable discomforts, they can initiate what clinicians call a cascade failure in treatment.
Okay, a cascade failure. Let's unpack that. Why is a little bit of nausea or, some occasional diarrhea a major clinical threat? What's the domino effect?
The problem is adherence. It all comes down to adherence. If a patient is experiencing significant recurring discomfort, they start to reduce their dose on their own,
Of course.
often to a subtherapeutic level that just won't achieve the weight loss or the A1C goals. Or even worse, they stop the therapy entirely.
And once they stop, all that protection is gone
Instantly.
instantly. Discontinuation means they lose the therapeutic benefit, which sends them right back to the ongoing high-level risks of chronic obesity and uncontrolled diabetes.
So you're talking increased cardiovascular events, worsening hypertension.
All of it. Diabetes progression,
Yeah.
mobility issues. The therapy's success depends on consistency, and these side effects are the single biggest barrier to that consistency.
So if you're a practitioner, treating the side effect isn't just about patient comfort. It's actually a critical, life-preserving strategy to maintain the efficacy of the entire treatment.
Absolutely. And if the symptoms get really severe, our sources highlight that this can lead to dehydration. It necessitates more healthcare encounters, ER visits, urgent care.
And it even impacts professional life through decreased work productivity or more sick days. This is a system-wide public health and, frankly, an economic issue, all driven by GI discomfort.
That sets the stage perfectly. So our mission today is to give you the shortcut to understanding the cutting edge of this field. We're going to synthesize a brand new formal clinical practice guideline, a CPG that was developed specifically to handle these common GI toxicities.
And then we'll take a high-resolution look at the specifics, the practical and often surprisingly strict details of administration, dosing, and the critical warnings for a key agent, semaglutide.
And finally, we're going to explore the 2024 guidance from the American Diabetes Association. It shows how the arrival of these powerful agents has just fundamentally changed the entire treatment hierarchy for type 2 diabetes, moving from its sort of traditional glucose-centric approach to a complication-centric one.
It's a huge shift.
A massive shift. So let's start with that immediate practical concern, the GI issues. They're so common, yet for years the guidance was, what? Kind of scattered. Why did clinicians need to develop a formal CPG? Didn't everyone just tell patients to eat smaller meals and, hope for the best?
That's exactly it. You hit the nail on the head. The management was largely anecdotal. There was tons of documentation of the problem, but no standardized, evidence-based roadmap for the solution.
I see.
A formal CPG was needed to pull together the best available evidence from research papers in databases like PubMed and CNA Air, and also non-research clinical wisdom, to create a unified decision tree.
So the goal was to combat that anecdotal fragmented approach.
Yes, and most importantly, to standardize care to prevent patients from abandoning the therapy.
It sounds like they recognize that without a clear structure, The GI side effects just become a self-fulfilling prophecy of treatment failure.
They do.
So what specific symptoms did this new standardized roadmap focus on?
The CPG focused on the 4 most common GI toxicities. So we're talking nausea, vomiting, diarrhea, and constipation. These are the main disruptors. But what's fascinating, and it really speaks to the evolving nature of medicine, is that even during the CPG's rigorous development process, the expert reviewers were already suggesting ways to improve it.
Oh, interesting. Like what?
Well, one expert specifically recommended adding the symptom of abdominal bloating to the CPG for future consideration.
You know, that detail about bloating is a great example of clinical nuance. It's different from, say, acute nausea, but it's just as disruptive to someone's quality of life.
Absolutely.
So how does the CPG categorize the severity? What are the practical steps a practitioner takes when a patient calls in feeling sick?
Okay, so the CPG operates on a critical 3-tiered system. The practitioner assesses the intensity of the GI toxicity and immediately assigns it to one of those 3 tiers to determine the appropriate standardized response.
And the response is designed to be the minimal necessary intervention to keep them on the drug.
Exactly.
So let's start with the least disruptive tier. A patient is new to the drug, has a little bit of stomach unease, maybe some mild constipation. What's the response for mild GI symptoms?
The management for mild symptoms is strictly supportive care.
Supportive care.
Right. This is where the clinician focuses on non-pharmacological interventions. We're talking about very practical advice. Small, frequent meals, avoiding high-fat or greasy foods that make that delayed gastric emptying worse. Increasing fluid and fiber intake for constipation, and maybe using some readily available over-the-counter remedies, low-dose anti-nausea medication or antidiarrheals.
And crucially, you keep them on the same dose of the medication.
The medication dose is maintained, absolutely.
Okay, that sounds like standard, sensible advice. But what if the symptoms progress? Patient's missing work, they're feeling significant distress, they're moving into that moderate range.
If the patient experiences moderate GI symptoms, the stakes rise and the intervention changes drastically. The management now necessitates holding the GLP-1 medication for 1 week.
A full week. That's a significant pause, isn't it? Especially when the goal is adherence.
It is, but it's a very calculated decision. These drugs, especially semaglutide, they have very long half-lives. A 1-week hold allows the drug concentration in the body to dip just enough.
To give them a break.
Exactly. It gives the patient's system a needed reprieve and allows those acute symptoms to subside. The clinician has to follow up to reassess symptoms once that drug concentration falls. The key is that this is a pause, not a full stop.
You're aiming to get the patient back on therapy.
Right, maybe at a reduced dose or the same dose, but after that break.
So moderate distress triggers a mandatory timeout. But if the patient is suffering from something truly debilitating, say severe vomiting that leads to dehydration, that's the highest tier.
Correct. Severe symptoms, the kind that might lead to an emergency room visit, severe dehydration, or just a complete inability to function, those may lead directly to drug discontinuation. Safety is paramount here.
And there's data to back that up.
Yes, our sources cite the work of Gorgorjo Martinez and colleagues, confirming that discontinuation is the appropriate safety-driven response in these really severe cases. The risk of an acute complication just outweighs the chronic benefit at that point.
That 3-step roadmap supportive care, 1-week hold, or discontinuation, that is, that's invaluable for practitioners. Now, for those of our listeners who are keen on the credibility of medical resources, let's look behind the curtain a bit. How was this CPG validated? How do we know it's not just a collection of opinions?
This is where the concept of rigor and diverse expertise really comes into play. The guideline wasn't just written, it was reviewed and validated by an expert panel of 4 subject matter experts.
And they were all prescribers.
That was the non-negotiable requirement. All 4 had to be active prescribers of GLP-1RA or GIP-GLP-1RA for adult weight loss.
Were these all endocrinologists? Or did they have a broader perspective?
The perspective was intentionally broad, which is actually a major strength of this CPG. We had a doctor of osteopathic medicine who was a rheumatologist and an associate professor.
Rheumatologist.
Yeah, with 15 years of experience. Her input is critical because she's using these agents not just for weight loss, but often to manage the systemic inflammation and autoimmune symptoms that are so common in patients with obesity.
That's fascinating. She's viewing the drug through a completely different lens than a traditional primary care doctor would. What about the other 3 reviewers?
The remaining 3 experts were all advanced practice registered nurses, APRNs, but again, specializing in totally different arenas. One with 25 years of experience focused on wellness and preventative care.
Okay.
Another with 21 years specializing in psychiatric and mental health.
Wait, hold on. A psychiatric and mental health APRN reviewing a GI guideline. Why is that diversity so important?
Because adherence often fails due to mental health issues. Things like self-sabotage or poor coping mechanisms when a patient is faced with side effects.
That makes perfect sense.
A psychiatric APRN brings a crucial perspective on how distress translates into poor adherence and how you counsel those specific patient populations, the patients who might be more susceptible to the anxiety or depression that sometimes comes with these huge lifestyle changes.
It ensures the guideline's useful in the real world, not just in theory.
Exactly. It ensures the applicability extends beyond simple biochemistry. And the fourth was in traditional family practice.
So to formally quality check all this diverse input, they use the Agree-To tool, right?
That's right. The Agree-To tool is essentially the gold standard for measuring the quality and trustworthiness of clinical guidelines. It's a 23-item checklist scored on a 7-point scale across 6 major domains.
Can you give us a quick snapshot of what those domains are checking for?
Think of it like a comprehensive audit. They check the scope and purpose. Did the guideline set out to do what it said it would? Stakeholder involvement. Were the right people, patients, clinicians included? Rigor of development. Was the evidence-gathering process robust?
And the others?
Clarity of presentation. Is it easy to use? Applicability. Can you actually implement this in a busy clinic? And finally, editorial independence. Was the guideline free from any undue influence?
It sounds incredibly thorough. So what was the final outcome of this multifaceted review?
The results showed overwhelming confidence. The guidelines scored favorably in all 6 of those domains. And most importantly, all 4 expert reviewers gave the overall assessment of the CPG the highest score possible, a 7, and formally recommended its immediate use in their own clinics.
That is a rock-solid endorsement. It tells you that this guidance isn't some theoretical exercise. It's a necessary, high-quality, validated tool designed to keep people safe and, critically, keep them on the medication that's changing their lives.
That's the whole point.
All right, that sets the management philosophy. Now let's drill down into the drug that has really defined this revolution. Semaglutide. It's available under several brand names: Ozempic, Wegovy, Rybelsus. Let's start with its approved mandates. What are the official indications for its use?
Semaglutide, across its different forms, is indicated for 3 major purposes in adults. The first is improving glycemic control in type 2 diabetes. The second is reducing the risk of major adverse cardiovascular events in those with T2D and established CV disease.
And the third is the big one.
And the third is chronic weight loss, strictly as an adjunct to diet and exercise.
The dosing strategy it's complex because it differs so dramatically between the T2D and CV indication versus the chronic weight loss indication. Let's focus first on the T2D dosing and why that step-up approach is so incredibly slow.
The slowness is the entire strategy for mitigating side effects. That's the key. The body needs weeks, even months, to adjust to the powerful effect of delayed gastric emptying.
So the initial doses aren't really for treatment.
No, not at all. For T2D and CV risk reduction, the initial doses are only for initiation. They are not considered therapeutically effective for glycemic control yet. They are, the training wheels.
Starting with the oral form, Rybelsus, which is, chemically engineered to be absorbed in the stomach.
Right. For the oral tablets, the patient starts with 3 milligrams once daily for 30 days. That's the mandatory initiation month.
A full month at 3 milligrams.
Yes. Then they titrate up to 7 milligrams once daily. And if, after at least 30 more days on 7 milligrams, they still require better glycemic control, then they can increase to the maximum dose of 14 milligrams once daily.
And here's one of those crucial little details that can trip up patients and even providers: the 14 milligram dose.
Yes. This is so important. Taking 2 7-milligram tablets to achieve a 14-milligram dose is explicitly not recommended.
Why is that?
The formulation is extremely sensitive to absorption parameters, and that specific instruction must be adhered to. It has to be the single 14-milligram tablet.
Now let's move to the subcutaneous injection, the ASIG injection, which is often Ozempic in this context. What is the typical titration schedule for T2D with the injection?
The subcutaneous injection follows a similar, very careful approach. It starts at 0.25 milligrams once a week for 4 weeks.
Again, initiation only.
Initiation only, not an effective dose. It then increases to 0.5 milligrams once a week. If needed, the patient remains on 0.5 for at least another 4 weeks before titrating up to the maximum T2D dose of 1 milligram subcutaneously once a week.
So we're talking anywhere from 8 to 12 weeks just to hit that maximum therapeutic dose for type 2 diabetes. That requires a lot of patience from both the patient and the clinician.
It does.
Now let's compare that to the chronic weight management dosing, which is often branded as Wegovy. This is where the doses get significantly higher.
That's right. The maximum maintenance dose for weight loss is more than double the maximum T2D dose. It really reflects the need for a greater pharmacological impact for chronic weight management. The escalation schedule is also much, much longer.
Walk us through that higher escalation schedule. It's quite a climb.
It's a 4-month climb. The escalation schedule for weight loss starts at 0.25 milligrams once a week for weeks 1 through 4. Then it moves to 0.5 for weeks 5 through 8. Then 1 milligram for weeks 9 through 12. And finally, 1.7 milligrams for weeks 13 through 16.
16 weeks, 4 entire months, just to reach the 1.7 milligram dose.
Yeah.
So what is the true goal dose for weight management?
The maintenance dose is reached at week 17 and onward, and that dose is 2.4 milligrams subcutaneously once a week. This 2.4 is the intended target for long-term chronic management.
But wait a minute. What if a patient is hitting serious GI issues at, say, the 1.7 milligram dose during that long escalation? What's the protocol?
The guidance is strict, but it provides some leeway to prevent discontinuation. If dose escalation is simply not tolerated because of side effects, the clinician should delay the dose increase for 4 weeks.
So you're basically repeating the prior step.
Yes, you're giving the body more time to adapt.
And what about that 2.4 milligram maintenance dose? What if they finally reach it and the side effects come back with a vengeance?
This is a really critical rule for adherence. If the 2.4 milligram maintenance dose is reached but cannot be tolerated, the dose can be temporarily decreased back down to 1.7 milligrams once a week.
Okay.
For a maximum of 4 weeks. After that 4-week reprieve, they have to either successfully increase the dose back to the target of 2.4, or the therapy must be discontinued entirely.
That 4-week limit is a fascinating clinical mandate. It tells you that the 2.4 dose is really considered the lowest effective therapeutic level for that long-term weight management indication.
It creates a very clear boundary. If you can't reach and sustain 2.4, the long-term benefit for chronic weight management is probably not sufficient to justify the drug's use.
Let's pivot to the administration rules, especially for the oral formulation Rybelsus. They are surprisingly meticulous. Why all the rigidity?
The rigidity stems from the fact that this is a peptide. It's fragile. It's easily degraded by stomach acid.
I see.
To enhance absorption, it's formulated with an absorption enhancer. But that whole process is highly sensitive to the presence of food, other meds, or even just too much liquid.
Give us the hard rules for the oral tablet.
It has to be taken with no more than 4 ounces of plain water.
4 ounces, that's just half a standard measuring cup.
Exactly. And it must be taken at least 30 minutes before the first food, beverage, or any other oral medications of the day.
30 minutes before anything else enters your body? That requires a dedicated commitment every single morning. I can only imagine how difficult that is for a patient with a rushed schedule.
It's a huge adherence challenge, and failure to follow it renders the medication largely ineffective. And on top of that, you have to swallow the tablet whole. You can't split it, crush it, or chew it.
Right. Now, let's get to the serious warnings. We've covered the GI issues, but what are the true critical precautions that require heightened clinical vigilance?
The foremost is the U.S. boxed warning concerning the risk of thyroid C-cell tumors, specifically medullary thyroid carcinoma, or MTC.
And what exactly triggered that black box warning?
The concern comes from animal studies. In rodents, the drug caused dose-dependent and treatment duration-dependent thyroid C-cell tumors at clinically relevant exposures.
Okay, here's where I have to ask a question. Is there any human data to back this up?
And that's the point of the caveat. The source material explicitly states that the human relevance is unknown.
Unknown.
We do not know if this effect translates to human beings, but because of the severity of MTC, the warning is mandatory based on the animal data alone.
So, based on this potential risk, who should absolutely never use semaglutide?
It is absolutely contraindicated in patients who have a personal or family history of medullary thyroid carcinoma, or in patients with multiple endocrine neoplasia syndrome type 2, which is a rare genetic disorder known as MNN2.
We also hear about pancreatitis a lot with this drug class.
Pancreatitis is a known serious risk. A specific instruction is that semaglutide has not been studied in patients with a history of pancreatitis, so clinicians should really look to other anti-diabetic therapies for those individuals.
And they have to monitor for it.
Constantly, they have to actively monitor for that sudden, severe abdominal pain that's characteristic of pancreatitis throughout the treatment.
And finally, the monitoring requirement seems pretty extensive. What goes into the clinician's checklist beyond just checking blood glucose?
Well, they need to monitor for signs of potential thyroid tumors, things like persistent hoarseness, difficulty swallowing, shortness of breath, or a new neck mass. They have to monitor heart rate, and critically, they have to monitor renal function in patients who experience severe GI events, because dehydration poses a real risk for acute kidney injury.
And for those patients using the drug for chronic weight loss, there's one more layer of safety monitoring tied to mental health.
That's right. For the weight loss indication, monitoring for suicidal behavior and ideation is also required. When you synthesize all these precautions, from the micromanagement of the dosing to the macromanagement of potential tumors, it just underscores that these are powerful drugs that require powerful, continuous oversight.
We've established the drug's power and the necessary guardrails. Now let's pull back and look at how this power has completely reshaped the clinical strategy for type 2 diabetes. Just to anchor everyone, T2D makes up over 90% of adult diabetes cases, characterized by that progressive loss of beta cell function alongside worsening insulin resistance.
And for decades, the mantra was so simple. Start with metformin, then intensify your treatment based purely on the A1C number.
Right.
The 2024 American Diabetes Association guidance signals a seismic shift. We are moving away from a solely glucose-centric model to one that is anchored on a holistic, patient-centered approach that prioritizes cardiovascular and renal risk assessment right after diagnosis.
So metformin is still the undisputed first-line therapy for most patients, unless there's a contraindication. But the decision matrix after that first step is fundamentally different now.
Precisely. If the patient has established atherosclerotic cardiovascular disease, that's ASCVD, a history of heart attack, stroke, peripheral artery disease, or if they have indicators of high CV risk, we no longer wait for the A1C to climb. We introduce these cardiorenal protective agents right away.
You stress that these protective medications have to be used independently of A1C. That's the conceptual leap I want to make sure the listener really grasps. We're using them not just as blood sugar medication,
No.
but as complication prevention medication.
Exactly. The evidence is so profound that the benefits minimizing ASCVD complications, reducing hospitalization for heart failure, delaying chronic kidney disease progression, they are achieved even if the patient's glycemic control is technically decent. Their impact on long-term morbidity and mortality is greater than just their glucose-lowering effect.
Let's define that high-risk population. Who falls into that category that now gets fast-tracked to these newer therapies?
The ADA guidance defines high ASCVD risk based on age and a combination of factors. It's patients aged 55 years or older who have 2 or more additional CV risk factors.
And those factors would be?
They include obesity, hypertension, smoking, dyslipidemia, so high cholesterol, or albuminuria, which is protein in the urine. If you meet that threshold, the clinician is strongly guided to start either a GLP-1 RA or an SGLT2 inhibitor with known CV benefit.
Now, I have to inject a moment of critical thought here. These GLP-1s and SGLT2s are often very expensive. They can be subject to restrictive insurance coverage, and the ADA is now recommending them as first-line agents for this massive high-risk population. What does that imply for the health system and for patient access?
That is the single greatest tension point in modern diabetes care. The clinical recommendation is scientifically sound. These drugs save organs and they save lives, but implementing this science requires overcoming these significant cost and access barriers. The guidance shifts the strategic choice, but societal issues around cost and equity then determine who actually receives the optimal care. It pushes the decision from being purely clinical to being both clinical and economic.
That is a crucial point. Moving back to the clinical strategy, does the ADA guidance prioritize one drug class over the other based on which complications are present?
Yes, the recommendations are highly tailored. If the patient has established heart failure or HF, the preference is strongly for SGLT2 inhibitors that have proven benefits for HF hospitalization.
Okay.
If the patient has established chronic kidney disease or CKD, especially with significant albuminuria, SGLT2 inhibitors are again typically preferred due to their robust evidence in reducing CKD progression.
So where do the GLP-1 RAs fit into that complication-focused scheme?
They are the immediate alternative if SGLT2s are not tolerated or are contraindicated. But crucially, several GLP-1 RAs are named as having proven CVD benefit: dulaglutide, liraglutide, and subcutaneous semaglutide. They remain powerhouse agents for overall cardiovascular risk reduction.
Okay, now let's consider the patient who is lower risk. They're under 55 or they don't have multiple cofactors. What dictates the choice of a second agent after metformin for this group?
For the low-risk population, the focus reverts to the core pillars of efficacy, safety, cost, and patient preference. Clinicians look at maximizing glucose lowering while prioritizing the avoidance of adverse effects.
Like hypoglycemia.
Right, like hypoglycemia and, critically, weight gain.
And this is where the GLP-1s just shine, even in the low-risk population, simply because of their unparalleled weight loss efficacy.
Absolutely. When you compare second-line agents, the weight loss efficacy gap is huge. Semaglutide is rated very high for weight loss. Dulaglutide and liraglutide are rated high.
And the older drugs.
Meanwhile, older classes like metformin and DPP-4 inhibitors are rated neutral. If weight is a priority, the choice is pretty clear.
This strategic shift leads us to the biggest change in the hierarchy of injectables. For decades, when oral meds failed, the next step was almost always basal insulin. The 2024 guidance explicitly prefers a GLP-1 RA over insulin as the first injectable. Why demote insulin after, what, a century of use?
It boils down to the vicious cycle that's inherent in type 2 diabetes. Weight gain worsens insulin resistance, which then requires more medication.
Right.
Insulin therapy, while powerful for glucose lowering, consistently causes weight gain. The GLP-1 RAs, on the other hand, promote weight loss, they improve insulin sensitivity, and they carry a lower intrinsic risk of dangerous hyperglycemia.
So in the new paradigm, insulin is officially considered the third-line anti-hyperglycemic agent, following metformin and a GLP-1 RA. That is a massive conceptual change.
It is. Insulin is now reserved for intensification after GLP-1 RA is maximized. The exceptions, of course, remain those acute life-threatening scenarios.
So severe hyperglycemia.
Severe hyperglycemia, catabolism, which is unexplained weight loss, an A1C over 10%, or blood glucose greater than 300. In those crises, insulin is still the immediate answer.
If a patient is put on insulin, the guidance introduces this critical warning about over-basalization. This is one of those nuanced clinical concepts that defines good practice. What exactly is over-basalization?
Over-basalization occurs when a clinician mistakenly keeps increasing the dose of basal or long-acting insulin because the overall A1C isn't hitting the target. The clinician is chasing the number by increasing the wrong tool.
But isn't basal insulin supposed to lower A1C?
Indirectly, yes. But its primary job is to suppress the liver's glucose production overnight and correct fasting hyperglycemia. It does very little to correct the glucose spikes that happen after meals, the postprandial hyperglycemia.
I see. So you keep increasing the basal dose, your fasting sugar looks perfect, but your A1C is still high because of those massive post-meal spikes that the basal insulin just can't touch.
Exactly. The attempt to fix postprandial spikes with basal insulin just results in hypoglycemia, often overnight, and it fails to adequately address the mealtime issue. It's an inefficient and, frankly, dangerous strategy.
So what are the clear clinical signals a practitioner must look for to recognize that they are over-basalizing?
The guidance gives 3 key markers. First, a basal insulin dose greater than 0.5 units per kilogram per day. That's a quantitative red flag.
Okay.
Second, post-meal blood glucose levels that remain stubbornly high, typically greater than 180. And the third is the A1C not meeting goal despite the patient having successfully achieved their fasting blood glucose targets.
In other words, if your fasting number is great but your A1C is high, stop boosting the basal dose. You need a mealtime intervention.
That's it.
And this flows perfectly into our final section, which is about the tool design for that exact mealtime intervention. So we just established that if patients over-basalized, the solution is to add a treatment that specifically targets those postprandial glucose spikes. That brings us to one of the key tools for immediate, precise glucose management. Fast-acting insulin, specifically Insulin Lispro, or Humalog. This is a fascinating example of chemical optimization.
It really is an exercise in pharmaceutical engineering. Humalog is a human insulin analog, which means it's a copy of human insulin, but with a tiny yet critical structural modification.
And what is that precise chemical adjustment that makes it so rapid acting?
The change is subtle, but it's profound. It's created by simply reversing the amino acids at positions 28 and 29 on the insulin B chain.
So you flip lysine and proline.
Exactly, you flip them. This creates the lysine B28 pro-B29 human insulin analog, which is the official identity of Lispro.
So, a tiny 2-amino acid flip. Why does that matter so much to the drug's speed?
In natural human insulin, those amino acids cause the insulin molecules to clump together into hexamers, which are these large, stable bundles. These hexamers have to break down into smaller active dimers or monomers before the body can absorb them. This breakdown takes time, hence the required 30 to 60-minute wait before a meal for standard, regular insulin.
And the Lispro modification, that flip, prevents that from happening.
That simple flip prevents those hexamers from forming efficiently. As a result, Lispro is absorbed much faster immediately after injection, which enables it to hit the bloodstream right when the glucose is flooding in from the meal.
So that structural change results in a fundamentally different timing profile. Let's compare the pharmacodynamics to standard human regular insulin. The potency is the same, but the speed is the real differentiator.
The speed is everything. Humalog has a more rapid onset of glucose-lowering activity and a significantly earlier peak.
Can you give us those peak times? How much faster are we talking?
In studies, Humalog reached peak serum levels between 30 to 90 minutes after dosing.
30 to 90. And regular insulin?
Standard human regular insulin, conversely, peaked much later, between 50 to 120 minutes. And Humalog also has a proportionally shorter duration of glucose-lowering activity overall.
This quicker action fundamentally changes patient behavior. It dictates a whole new rule for timing the injection relative to food.
It is the single most critical piece of patient advice. When used as a mealtime insulin, Humalog should be given within 15 minutes before or immediately after the meal.
That 15-minute window is dramatically different from the old rule. It provides so much more flexibility, and it prevents that gap where the patient injected, but the insulin hasn't started working yet, leading to a huge glucose spike.
That flexibility is a major benefit, and clinical trials confirm this advantage. In both type 1 and type 2 patients, Humalog reduced postprandial glucose more effectively than human regular insulin did.
And there was a crucial safety benefit for type 1 patients noted as well, right?
Yes. Type 1 patients treated with Humalog had fewer hypoglycemic episodes during that vulnerable overnight period between midnight and 6 a.m.
That's huge.
It is. It confirms that its shorter duration and faster clearance translate to safer control overall.
Now for the practicalities. Does the injection site still affect the absorption rate even for a rapid-acting analog like this?
It does, though the differences are smaller than with regular insulin. Humalog is absorbed faster at abdominal, deltoid, or femoral sites compared to human regular insulin. And crucially, after abdominal administration, the drug concentrations are slightly higher and the overall duration of action is slightly shorter compared to injections in the thigh or the deltoid.
That's a level of precision the patient really needs to understand. Abdominal injections give you the quickest, sharpest, but shortest action. Finally, let's cover the high-stakes safety rules for administration, particularly for those using insulin pumps.
For use in select external insulin pumps, which is an approved use, there are two absolute safety mandates. First, Humalog should not be diluted or mixed with any other insulin when it's loaded into the pump reservoir.
No mixing in the pump, got it. And the rule regarding the pump hardware itself.
The infusion set and the insulin reservoir must be replaced every 48 hours or less. This is a strict safety and efficacy requirement.
48 hours.
And on top of that, Humalog must not be exposed to temperatures above 37 degrees Celsius or 98.6 Fahrenheit while it's in the pump.
That 48-hour replacement rule is non-negotiable for safety. And if a patient is mixing it with a longer-acting insulin for traditional vial and syringe use.
If mixing in a vial with a longer-acting insulin like NPH, Humalog, the rapid-acting agent, must always be drawn into the syringe first.
The fast one first.
The fast one first, and the injection must be made immediately after mixing. The overall message is that precision in administration is just as important as the precision of the drug design itself.
We've truly seen the dual strategy of modern chronic disease management today. You have this massive strategic shift in drug selection to mitigate long-term complications, coupled with the fine-tuned engineering required to manage glucose on a minute-by-minute basis.
It connects the macro-level policy changes of the ADA with the micro-level chemical modifications that are needed for patient safety and efficacy.
Okay, let's synthesize the massive shifts we've covered in this deep dive. I think the core takeaway is that the GLP-1 revolution has forced medicine to rethink its entire strategy for treating obesity and type 2 diabetes.
And that rethinking led directly to the standardization of care. We saw the development of the Clinical Practice Guideline, a necessary tool to move GI toxicity management from just anecdotal guesswork to a standardized efficacy-preserving protocol.
Right, using that clear, supportive hold or discontinue decision tree.
Exactly.
We also analyzed the extreme precision required for semaglutide dosing, highlighting that 4-month titration schedule needed just to reach the chronic weight management target of 2.4 milligrams and those critical administration rules like the 4-ounce water limit for the oral formulation.
And we established the true paradigm shift mandated by the 2024 ADA guidance, prioritizing cardiorenal protective agents like GLP-1 RAs and SGLT2 inhibitors independent of A1C goals for all high-risk patients.
A strategy that inherently sidelines insulin as the first injectable choice, acknowledging that critical clinical trap of overbasalization.
Right.
And finally, we close that loop by looking at the elegance of precision timing in tools like Insulin Lispro, Humalog, a simple amino acid reversal, creating a rapid-acting profile, which is the perfect tool for addressing the postprandial glucose spikes that basal insulin just cannot solve.
It demonstrates that modern care is this sophisticated balancing act between the biggest health-saving breakthroughs and the most minute yet crucial details of chemical structure and administration.
It is clear that the tools available to clinicians are more powerful than ever, yet the barriers to successful long-term care remain pretty significant. We know type 2 diabetes is a progressive disease, and achieving optimal control requires timely intensification. Yet physicians frequently fall prey to what's called clinical inertia, failing to adjust or intensify therapy when it's needed.
And that inertia costs patients valuable time, and it exposes them to unnecessary risk.
And this leads us to the final, provocative thought for you to explore after this deep dive. Our sources highlight a deeply troubling disparity. African American and American Indian Alaskan Native individuals show demonstrably lower initiation rates of these crucial, newer cardiorenal protective medications, the GLP-1 RAs and SGLT2 inhibitors, despite often carrying higher complication risks from type 2 diabetes.
A huge disparity.
So if we know the benefits of these drugs act independently of A1C to save lives in high-risk groups, and we acknowledge that clinical inertia is a systemic problem, what societal or system-level barriers, beyond just the inertia of the prescribing doctor, are truly preventing these life-extending therapies from reaching the racial and ethnic subgroups who need them the most?
That question shifts the focus from the lab bench to the clinic door, demanding we consider access, awareness, and equity right alongside pharmacology.
Indeed. Until next time, stay curious and well-informed.